Welcome to the Editor's Podcast for the Journal of the Academy of Nutrition and Dietetics. I am Dr. Linda Snetselaar, Editor-in-Chief of the journal. And today during our podcast, we'll be discussing the manuscript Use of Water Filters at Home Reduces Sugary Drink Consumption Among Parents, Infants, and Toddlers in a Predominantly Hispanic Community. Results from the Water Up at Home intervention trial. And this particular article includes what I think is a very interesting concept. That is the idea that water filters, which would normally be ensuring safe water supplies, have an added benefit, and that is to reduce sugar-sweetened beverage intake. And I think that's quite novel and very thought-provoking. And I have with me today the author of this manuscript, Dr. Uriyoán Colon-Ramós, who is an associate professor of nutrition and global health in the Department of Global Health at the Milken Institute School of Public Health at George Washinton University. Welcome, Dr. Colon-Ramós.
Thank you so much for having me, Linda. It's a pleasure to be here.
So what I would like to do in the next few minutes is just ask you some questions that are related to this very intriguing article that you have written. And the first question is, what prompted the use of water filters in this intervention?
Yeah, so it's a really interesting story. We started in about 2014 with a community participatory research approach in this community, which is predominantly Central American immigrants right outside of Washington, D.C., but still considered in the Washington, D.C. metropolitan area. And nutrition, the aspect of nutrition, which is what my formal training is on, came kind of as a side benefit, if you may, to their concerns. So it originally started, this is a community academic partnership that was working on mental health, anxiety, and especially youth risk behaviors in this particular community. And nutrition came up during a photo voice approach, where the youth were asked about the attributes of their community, and they said that they wanted to work on having more access to healthier foods in their community that they considered to be a food swamp. So lots of foods that were available, but nothing that they considered was particularly healthy according to what they had learned. And so we spent a good year and a half doing formative work. We did photo voice interviews after that with mothers, and interviews with different stakeholders in the government, in schools, focus group discussions, trying to define what that would look like within nutrition. And we also had a community advisory board that was working on the mental health and youth development aspects. And we diversified it to work a little bit more with us to define this aspect of nutrition until we defined it as that they wanted to work on sugar drinks and excess juice consumption for infants and toddlers, although this was kind of a larger community effort. But this one in particular focused on infants and toddlers. And so as part of that effort, we then started putting our heads together and thinking, when I say we, this is, again, community academic partnership, and I'm part of the scholarly part of it in the research. And we started thinking, well, you can't just tell people not to drink. What are we going to promote instead as an alternative? And, from the nutritionist perspective, you want to promote water. That's what's healthy, and that's what's natural, and it doesn't have any calories. And in particular, we wanted to promote tap water because our community advisory board included members of the community and NGOs that were working with the schools, the public schools, to make them green, to get that certificate of them being green schools. And in doing formative work, we realized that none of the parents consumed tap water, that they consume water, but it was all bottled water, mostly those little bottles of water that you purchase at a Costco, larger quantities. And when you go to the restaurants in the community, you sit down and nobody offers you tap water to drink. Nobody fills your cup with water. If you ask for tap water, they will bring you a bottle of water. And so started wondering why that was happening. And I would just want to make the pause that this was right before Flint in Michigan, that potable water crisis there. But it happened during Flint happened during our formative work. And we started then wondering about the issue of water safety in the community, both in DC and the families that lived right outside of DC in Maryland, and started making liaisons with the municipal water providers who assured us that the water is clean. And so started wondering about where this was coming from. So the intervention took a while to develop, lots of formative work that went into it. But at the end of the day, when we tried different things, we thought, well, what about if we want to make water accessible at home and affordable, and we want to promote it, and they're already drinking bottled water. And from the formative work, we knew that drinking bottled water could be a challenge because they felt like they had to ration the bottles of water, because otherwise they had half consumed bottles of water all over their homes, because their children would leave them and then they would leave them, etc. And so we said, well, why don't we provide them with just a water filter, just to give them that security, since we can't really test the water. Many of these families lived in rental units, and it's very complicated to test the water without having them or anyone else in the apartment building use the water faucet for 8 hours prior, plus, water. There's a lot of variability in the water, plumbing as well, depending on the day and the temperature, etc. So we didn't want to go that route, and that's what ended up kind of like putting that part of the intervention that was an educational intervention. It was theory-based with self-efficacy constructs, but also providing a water filter, just the picture of a water filter to be used at home as a way of making water more accessible in their homes.
Yes, thank you so much. Very, very interesting story. I wondered if you might highlight some of the data that you include in your article, which focuses on the Water Up at Home intervention trial.
Yes, so we were collecting data from using the beverage questionnaire, BevQ, that was adapted for preschoolers, which we further adapted for infants and toddlers. That was developed elsewhere, and we had used it here for adults, and then we adapted the preschooler one. So it is not a 24-hour recall, and we could not calculate calories without making certain assumptions, but it was a quick assessment of what they were drinking in terms of categories of different beverages. And we included water and from different sources, tap water, bottled water, and filtered water. It was one of the adaptations that we made. And so what we found was that they were drinking, it was a randomized controlled trial, and we provided the Water Up at Home intervention. Families were randomized. Just want to clarify that this was in partnership with the Early Head Start program in Centronia and in Gaithersburg with Shepherd Pratt at that point, because they have a home visiting program, and they were already doing a lot of things in the center, but they were concerned about what was happening in the homes. So we used their platform of home visiting to deliver this curriculum that was co-developed with them. And we find that sugary drinks, which was a general category of various beverages as standard as possible, was significantly decreased after the intervention. So let me just take a step back. This was an intervention that was designed to be 12 weeks, so about 3 months with some leeway, because we take into consideration that families may be traveling, that some things come up, and we had a guide. So it was more of an intervention with a guide, and there was a guide of teaching and self-efficacy and motivation for the parents to replace one of the drinks that they drank and that their children drank with water, or dilute it with water, which was something else that came during our formative work, instead of a full replacement. And so that was about 3 months. And the intervention families received the educational curriculum, and they received the water up, the water filter, which was happened to be a pure PUR pitcher, just like the Brita filter used at home. And they had a few other prompts. We had a book that was for coloring was developed by the Santa Clara County in California, called Otter the Potter, about drinking water. And we also had different materials for the children to develop their gross motor skills and their fine motor skills, because that's part of the early Head Start curriculum. But everything around water and serving mom and dad the water and preferring water, setting up the table with water, that kind of thing. Meanwhile, the comparison group, what we call the control group, received the standard curriculum of early Head Start, which is all about educational development. But they also received a water filter pitcher without any additional instructions about how to set it up or why we were providing it. It was just a standard kind of thank you, token of appreciation. And we did that for many reasons, which I can expand upon. But to our surprise, both groups decreased significantly their intake of sugary drinks and increased significantly their intake of filtered tap water consumption from baseline. So at the end of the day, we cannot see any significant differences between the groups. And what we're thinking is that this was all due to the water filter pitcher, or a big part of it was due to the water filter pitcher. And we actually did explanatory interviews afterwards with parents from both groups to try to understand how that could have happened, or whether it was a Hawthorne effect. And what we conclude is that all families, whether they were randomized to either group, used the water filter pitcher, that they felt more secure with a water filter pitcher, that they, whether it was actively or unconsciously, because they were consuming more water, that seemed to have somehow displaced the beverages that have added sugar in it, and that had to do with them not rationing the bottled water because they had more water that was freely available. That came across very strongly in both groups. And so we do think strongly that it had to do, the findings suggest that it had to do something with an almost unconscious replacement of beverages, because they had more availability of water, not as much the aspect of education, but more the aspect of availability of water.
Very interesting. Can you tell us why you think these outcomes are clinically relevant in terms of validating the individual's concern about water safety?
Yes, because I think that we typically don't think, when we're thinking about in our world of nutrition, and enticing people or motivating people to drink water, we might not think about the aspects of water safety, whether it's perceived water safety or actual water safety. And here in the United States, we have pockets of entire communities and populations that suffer from water insecurity, whether they don't get enough water or don't get water that they consider is palatable or that it is potable, or get a number of different water breaks. And we tend to not think about that when we're thinking about sugar drink intake, just such an obvious risk factor for many diet-related chronic diseases and diabetes. So I think in general, dietitians, and the full disclaimer that I am not a dietitian, but I greatly value what they do, look at the whole person. And I think that there is a deep understanding there of what that whole person may have access to or should be consuming. But I think clinically, we want to start thinking beyond the individual to, okay, what's happening at the home of that individual? And maybe this individual is going through great lengths to obtain water to be able to, because they know it's better for them. And they might spend, we know, for example, that families that are minority, for example, Hispanic families, African American families in the United States spend a significantly larger amount of their annual income on bottled water compared to non-Hispanic white families and communities. I think it's something like 16% of their annual income on bottled water, and they tend to mistrust more the tap water. And overall, we have had these observational studies that seem to suggest that people who drink or mistrust tap water don't drink as much water in general, but also drink more sugary drinks. We just didn't know the causality of it. But now thinking about the findings of the randomized controlled trial and the potential suggestion that when we provide or make this water more accessible, there might be a replacement, whether it's conscious or unconscious, of sugary drinks. It has a lot of clinical relevance because we can start by looking at the entire home or the infrastructure of the home or the community in which dietitians and doctors are working in, and understanding, well, is there potable water available, and what can we do to make that more accessible to families that are not drinking tap water, and maybe they're not drinking it, they haven't even realized that they're drinking more sugary drinks because they don't have as much access to tap water. Maybe that's something that they haven't even consciously or actively made the connection, but that it's happening in terms of behavior. And I think it pushes us to think beyond restricting sugary drinks as an alternative or talking about the negative effects of sugary drinks, but also touting and making more accessible, palatable, affordable, and safe tap water in these communities. And what are the many different ways of doing that, whether it's through a water filter or working in more upstream approaches with municipal water providers or well water providers. The water provision, tap water provision in the United States is another different world, and it's fascinating, and I think could be a great ally to nutrition, to the nutrition field and to dietitians. We could somehow, if we could, make that connection and synergize our priorities with their priorities and their priorities with our priorities in terms of health.
Yes, that brings to mind the idea too, particularly in this population that you were working with. What are some of the barriers to actually using water filters?
So that's a really interesting question, and one where I have a couple of thoughts, and we have delved into a few explanations through formative work. Water filters, you would think that it's not a very expensive, especially these ones. They're just pitchers, they're not very expensive. It seems a little bit far-fetched to think that just a water filter would change this behavior. But I think what we're seeing here, and in taking this with literature that has been published elsewhere, it seems to be that the tap water mistrust is divided into almost two different things. One is a deep mistrust about whether there are some things that are really, really bad with tap water. We're just not sure what it is. And even a water filter is not going to take care of it. And then there are the other subscribers of another opinion, or community members of other opinions, where they may use the water filter if their concerns are not as deep, if their concerns are mostly related with the flavor of the water, the appearance of the water, the smell of the water. So the kind of what we call the organoleptic qualities of the water. And I think what is happening in this particular community is that those people that were able to change their behavior just by the provision of a water filter, maybe their concerns didn't run as deep, and they were able to see what we found through the interviews is they were able to see the filtering process, and that made them feel secure in the filtering process, and they could taste the difference, and the taste seemed to be related in their minds. They related it to the safety of the water, the cleanliness of the water. But there's still deep mistrust in this community, and there were other parents who, even though they used the water filter, they did so with some hesitation about whether the water was still clean. They did it because they trusted the home visitors. Remember, this was an intervention that relied strongly on the home visiting program of the early Head Start. So these are home visitors that were Latina, they were from their same country, and they have an established relationship with these families in helping them establish goals for their families, etc. So these are people that are deeply trusted, and they brought the water filter. So they in a way trusted the water filter because it was almost endorsed or brought by the home visitors that they trusted themselves. But in the interviews, you could see that they still hesitated. Some of them still hesitated about wondering if it was really still clean. And there were a few cases when families would use the water filter pitcher as a pitcher for bottled water, meaning that they would buy the bottles of water and pour it in the pitcher. And so there we're thinking maybe it was just more of an aspect of making the water available in the fridge, making it available in the home so that they didn't have to ration it, as opposed to having little individual bottles all over the house with little bits of water everywhere. But yes, there seems to be a deep mistrust in this community and other communities, and I think that's related to trusting government as well, to associate it with a water quality that even the use of a filter may not mitigate. And that's just something that probably needs to be addressed by other interventions.
Yes, thank you so much. Those comments are very enlightening. My final question relates to use of this data. I'm wondering, how might the RDN use some of what you have just talked about in clinical practice? And additionally, what are the implications beyond clinical practice?
Yeah, so for clinical practice, one of the things that we did one-on-one that worked really well, and then I know that RDs do as well, is this kind of goal setting and motivation, where they ask the participants what is their typical go-to drink, and among those, then typically those are going to be drinks with added sugar in it. And then they asked the participants to set their own goals about for the next week, since this is a weekly visit, what is their goal for reducing it. Sometimes it was coffee, so it has nothing to do with water. It really has to do with reducing the amount of sugar that was added in there. But because we provided the water filter, then we also encouraged them to just drink. That encouraged them to drink more water. We encouraged them to drink more water, and we also said that they could dilute some of the juices or other things with water. And apparently this is already something we later learned through the interviews. This is a piece of advice that they get from their pediatricians and from the nutritionist at WIC as well. So they get a lot of, in this particular community, they get the juices and from food vouchers and beverage vouchers from WIC, but at the same time, they're getting that information about please dilute this juice, or just make sure that you're not providing so much juice to your infant or toddler following the pediatrician's guidelines. And so there's that clinical aspect of what to do with the individual in the home, which is about understanding where they're able to get an alternative to sugary drinks and realistically setting a goal to decrease it week by week. And that's what we saw that they kept, that really helped, and that they kept setting more and more ambitious goals for themselves and for their infants and toddlers as they felt better in replacing one thing for the other or diminishing the amount of sugar that they were drinking. But then the other thing is, there are two other lessons to be learned here. I think an opportunity for better alignment between the messages that we're providing across different healthcare providers or service providers in this community. And specifically, I'm referring to WIC because it came up over and over again in our interviews, where they get the beverages that families are getting mostly come from either their own budget or WIC. And yet they're getting messages from pediatricians and even WIC nutritionists about how they should be somehow rationing these juices, for example. And so I wonder if there's a better way of aligning the messages or providing access or understanding that they should have access to safe, palatable water before making that type of recommendation, or alongside that type of recommendation, rather. Because otherwise the parents are spending, and they do spend, a lot of their income on bottles of water, which is also not great for the environment, and it's also not incredibly affordable, especially since they're throwing away a lot of the water that's left over in the bottles, apparently. And so that's one opportunity for better alignment and beyond clinical work, or maybe even within clinical work. And then the other thing that we're thinking is how we can better work from a systems perspective, because providing water filters is not necessarily a sustainable intervention. It's not necessarily an affordable intervention. We had to replace water filters and provide filter cartridges for refills because parents were using it so much. And so, we're not in the business of making business for the water filters necessarily. That seems to me like a Band-Aid solution to a deeper problem that has to do with water systems, with potable water systems, and maybe getting behind the rallying for better systems of infrastructure for water, maybe supporting those, maybe understanding if those are set in better ways, could we reinforce that perspective that water is safe to drink, if indeed it is, because that's also another question. And would that have an impact overall in sugar drink intake? And not just sugar drink intake, apparently water, there are a number of studies that suggest that also drinking water may change your dietary quality and may have implications, water security, food insecurity. So that is a whole field of research, I think, that needs to be, right now it is working a little bit in divisive sectors, or maybe not divisive, but independent sectors that don't talk to each other. But then it's time now to start thinking about how those sectors converge, thinking about how we can better leverage their priorities and our priorities for an overall better nutrition from a systems perspective. And thinking about water, we often don't think about water when giving nutrition advice. Well, here in the United States, we do a little bit better. I work in Latin America as well. So I think we do a little bit better here. but it's not your typical go-to to think about water systems. We think about limiting unhealthy, but we don't. We want to also emphasize the providing more attention to the alternative, the healthier alternative, and making it easier for families. So those are the three main points, clinical and beyond, that I would emphasize in terms of implications for findings.
Thank you so much. Very thoughtful ideas. And what impresses me, I think, is that there's so much research left to be done in this particular area. And you have thought through many of the ways in which to work through the barriers, for example, but also ways that would be very helpful to the kinds of communities you've been working in. So I just want to, in summary, thank you for providing these insights into what I think is a very unique discovery that you have had through your research. And I wish you continued success in the area of research related to water filters and how they may change other eating habits that are connected.
Thank you
Again, thank you.
Thank you, Linda. It was my pleasure.